Hello and welcome to the first of the Osteoarthritis Summit debate series, where we're talking about corticosteroid injections. Are they helpful or harmful? These are injections that are widely and commonly used for the management of osteoarthritis, have been used for decades, and there's increasing evidence at present about the duration of their effects and their potential for toxicity. So in an effort to try to address some of the dissent within the field, we thought it would be very helpful and healthy to debate that topic with two wonderfully well-renowned international speakers who have great expertise in this field to shed some light on this incredibly controversial area. To give you a sense of the rundown of order, so the first 5 minutes I'll talk to you. We'll then do a Zoom poll to ascertain what your perspective is at the beginning of the debate. I'll then pass off to the affirmative speaker, Margaret Koppenberg, before handing off to the negative speaker, Ali Guermazi. And then each of the speakers will be provided a 5-minute rebuttal before opening it up for questions. A further Zoom poll about again, your perspectives on the use of steroids in osteoarthritis, but also a question about the winner of the debate. And then we will, at the end, announce the winner. I would like to begin by thanking a number of different organizations who've been really supportive and instrumental in making this a possibility. In particular, the Southern Medical University in Guangzhou, China, the Osteoarthritis Action Alliance, the Osteoarthritis Foundation International, and the Osteoarthritis Research Society International, and really appreciate their support in bringing this to fruition. I'm just going to spend a few moments here because what I'd like everybody to do, particularly those who want to ask questions, is to log into Slido, so www.slido.com. And as you do that, what you'll notice is there's a code, an opportunity to insert a code. And this is where you'll be entering your questions. The benefit of using Slido is that that allows us to capture those questions, but more importantly for you, to rank the importance of those questions. So that way, when we get to the question segment, you can highlight the questions that you most want the speakers to address. So again, if you go along to www.slido.com, you'll see where you can join as a participant. And what I'd like you to do is to enter that code. So the code again is 153915. And then in there, you can rank the questions themselves. Ali, you're the only person I can see on the screen. Did that work for you?
Yes.
Yeah. All right. Brilliant. All right.
I can see it. Yes.
Excellent.
Can you see me?
Not as yet, Margreet, but keep trying. I can see you on my slides, but that's not the same as your live video. But I'm sure you'll come on in a second. Now, firstly, just to introduce our speakers, our affirmative speaker is Margaret Koppenberg, and hopefully we'll see her live in a minute. But Margreet is a professor of rheumatology at the Department of Rheumatology at Leiden University Medical Center. She's a rheumatologist and epidemiologist, and since the year 2000 was appointed both at the Departments of Rheumatology and Clinical Epidemiology at Leiden University Medical Center. And so Chris can see Margreet, but no one else can see Margreet. That's a curious state of affairs. Anyway, so Margreet anyway is our affirmative speaker. So many people can see Margreet, which is wonderful. I'm really pleased you can all see Margreet, but hopefully we'll also be able to see Margreet in a minute. Okay. And our negative speaker is Dr. Ali Guermazi, who's a French board certified radiologist, and Ali's interest is in musculoskeletal diseases, and in particular has made important scientific contributions to the diagnosis and disease progression assessment of osteoarthritis using MRI. And much of his work is focused on identifying structural risk factors for developing and worsening osteoarthritis, and he's been instrumental in developing a number of scoring systems and has published widely in the fields. Okay, now without further ado, what I might do is open the first poll. And this is really just to get a sense of people in the audience. Would you recommend a steroid injection for knee osteoarthritis? And this is obviously us just trying to get a sense of your perspectives before we get started on this debate. You can probably see that happening live on your screen, but we'll just give it a moment so that we can capture most people's votes. Hopefully it's working well for you. All right, it looks like it might be slowing down. Hopefully most people have had an opportunity to vote. And like any good election, there appears to be a good spread. What we might do, and the reason for there's no it depends, Marie, is that we really would like people to make a vote one way or another. And obviously we're only giving you 2 categories because there's a lot of caveats in and around this. So we might end the polling there, Lon, and show us the results. And what you can see there is that the yes vote for having a steroid injection for knee osteoarthritis is a slight winner with 53% of people. And Lon, we might stop sharing those. Okay, so 50-50 split. We'll do that vote again at the end and see if there's been any change in the manner of the voting based upon our presenters' work tonight. Okay, all right. So we might go to the first affirmative speaker, and that's Margreet, and we'll just click on here and
Good
get
morning.
started.
First of all, I want to express my gratitude to Dr. David Hunter for the invitation for this debate. It is not easy to compete with Dr. Ali Guermazi, who already wrote several articles about this topic. I work as a rheumatologist, treating patients with osteoarthritis and other RMDs and performing OA research, but I'm not a specialist on this particular topic. From my experience in the clinic, I know that an inter-articular steroid injection can give temporarily pain relief. So when there is a flare, this is a useful treatment option. But what is the evidence to do this? That is what I will discuss with you in the coming presentations. These are my disclosures. Corticosteroids are hormones produced by the adrenal cortex. Their structure and biological effects have been elucidated by Kendall, Reichstein, and Hensch, for which they received the Nobel Prize in 1950. The pharmaceutical industries developed synthetic drugs with corticosteroid effects. In 1951, Professor Hollander and colleagues published a paper in JAMA in which they showed the efficacy of inter-articular steroids in patients with rheumatoid arthritis, osteoarthritis, and other RMDs. They gave 25 milligrams hydrocortisone or cortisone as often as necessary to maintain the beneficial effects, which were less joint swelling and alleviation of symptoms. The beneficial effects lasted on average 10 days for the hips and 3 weeks for the knees. He advocated the use especially in those patients when only one or a few joints were affected. That's what we currently still do. From the 1950s onwards, inter-articular corticosteroid injections became quite popular. Many case series showing efficacy were published. However, also discussions and controversies about the application arose. About their efficacy, which reported to be transient and of limited effect, as suggested by a controlled study by Miller, where steroid injections did not seem to do better than placebo after 6 weeks. About the most efficacious corticosteroid derivative. About the injection technique. and about joint destruction that was described after repeated inter-articular injections. Chandler and colleagues described the case of a woman with hip OA that received monthly injections with 50 milligrams of hydrocortisone, whereafter her hip became totally destroyed after 18 months. The questions arose, why would an injection with steroids in OA joints work? After binding of corticosteroids to the intracellular receptors, a variety of anti-inflammatory effects is set into motion. In the OA joint, inflammation with synovitis often plays a role. So it was hypothesized that inter-articular injections with corticosteroids could be efficacious by their anti-inflammatory effect. And this is also supported by their speed of onset and their effect on knee temperature and circumference as seen in the clinical case series. Studies in experimental rat and dog models of OA show a decrease in synovitis after inter-articular injections and underscore the hypothesis. And here the result from such a study in dogs who got an ACL injury performed by Pelletier is shown. You see a decrease in an operated inter-articular treated knee, panel D, versus an operated knee, panel B, and panel A is the unoperated control. In preclinical studies, also beneficial effects were seen on cartilage degeneration and osteophyte formation, suggesting that also other mechanisms of action might play a role. The anti-inflammatory mechanism of action was supported by in vivo studies in patients with knee OA that received a steroid injection. Dr. Keane and colleagues showed in a randomized controlled study the efficacy of 80 milligrams methylprednisolone on synovial thickness and effusion as assessed by ultrasonography after 1 week, which is depicted in the table. Recently, this was shown again by Mendes et al. The same was found using dynamic contrast-enhanced MRI in 2 observational studies by Wenham and O'Neill and colleagues. Here I show efficacy data of 80 milligrams of methylprednisolone in the study by O'Neill and colleagues. They showed a significant decrease in synovial tissue and fluid volume after 1 week. Interestingly, in the observational study by O'Neill, also a difference between a decrease in synovial tissue and fluid volume between those who responded and who not responded according to the OMERACT-OASI criteria could be shown. Those who relapsed with an increase in pain also had a significant increase in synovial tissue volume during follow-up. In those who did not relapse, this was not seen. As can be seen in the table below, there was a significant association between the change in synovitis volume and the change in pain. These data further support inflammation as target of treatment. Efficacy of inter-articular steroid has been shown on individual level in case series. But what about efficacy on group level in randomized placebo-controlled clinical trials? Although inter-articular injections are given in any osteoarthritic peripheral joint and also in the spine, most evidence is available for the knee and hip, and therefore I will limit this presentation to injections in these joints. In 2015, Uni and colleagues published a Cochrane review including 27 trials, showing a beneficial effect on pain and function. However, they concluded that the benefits after 1 to 6 weeks remained unclear because of the quality of the trials and the heterogeneity between the trials. In the last 5 years, since the review by Uni, several placebo-controlled randomized trials with low risk of bias have been performed. Also, these trials show symptomatic benefit for inter-articular corticosteroid injections at short term. Naim et al. Performed a recent systematic review with meta-analysis in which RCTs were summarized comparing inter-articular steroids with placebo or active comparators. You see here the forest plot for efficacy on pain on short term within 6 weeks and midterm between 6 and 24 weeks depicted. An effect on the short term could be shown. Efficacy of a single injection diminishes over time, and that's indicated in this graph based on several studies. A few studies have investigated multiple steroid injections at predefined time points to study efficacy at 1 year or longer. In clinical practice, this is quite unusual, since injections are not given when not needed. These trials did not show long-term efficacy on pain. These data are in accordance with a network meta-analysis using a Bayesian random effects model by Benuru and colleagues, showing an effect size for inter-articular corticosteroids of 0.3 against inter-articular placebo, which is better than acetaminophen and NSAIDs. 5 randomized placebo-controlled trials have been done in patients with hip OA, of which 4 with 238 patients were summarized in several systematic reviews with meta-analysis. Trials duration was maximal 26 weeks, with different assessment points over time. The quality of the studies is limited, and there is heterogeneity between studies. Here, data from Benuru are depicted. On pain, a significant effect was seen. The effect on function was not significant. The efficacy in knee and hip OA patients was supported by using individual patient data from the OA trial bank. Up to 4 weeks, so short term, clear efficacy was seen around 80 millimeters on a 0 to 100 scale. On the midterm, up to 3 months, efficacy was clearly diminished. No efficacy up to 1 year was seen. So, evidence underscores that steroid injections are efficacious. Response rates reported is between 62 and 71%. But there is variability in the response and duration of response between patients. Therefore, studies and systematic reviews have been undertaken to identify predictors. Features studied are several inflammatory signs, clinical characteristics as pain, local tenderness, and several demographic characteristics. Results have been inconsistent, so currently no personalized medicine is possible. In the past slides, I showed you the short-term benefit of a single steroid injection on symptoms. Any drug has, next to positive effects, also side effects. So how is that for inter-articular injections? Do inter-articular steroid injections outweigh the risk? In general, single inter-articular injections are considered safe. In most studies, it is reported that side effects are due to inter-articular steroids are similar to placebo. However, details are rarely given. This is also reflected by the data from the systematic reviews. In the large systematic review by Uni and colleagues on knee OA, no differences were depicted for patients experiencing any adverse events and serious adverse events. The recent trial by Konigin et al. Investigated triamcinolone acetate in immediate release and extended release form and reported more details. Frequent reported adverse events were arthralgia, headache, and back pain, but there was no difference between triamcinolone acetate and placebo. Also, the systematic review by McCabe on hip OA, no difference between steroids and placebo were indicated. Are there then no safety issues at all? No, but safety issues are well known and by many clinicians already taken care of in the precautions they take, such as the most feared septic arthritis. However, its incidence is very low. Recently, a study in Denmark estimated a risk based on registered data of 0.08%. Systemic effects can be seen. since the steroid will leak out of the joint cavity. An increase in blood glucose level in patients with diabetes mellitus. In a systematic review incorporating 7 small studies, a substantial increase was seen in 4 studies. In many patients, post-injection hyperglycemia occurred within 24 to 72 hours. So regular glucose level checks for these patients is advised. Hyperglycemic complications were not mentioned. Studies in patients, predominantly with an inflammatory RMD, showed an effect on the hypothalamic pituitary adrenal axis. And here a drop in cortisol after 24 to 48 hours was seen, which recovered after 1 to 4 weeks. I showed you many data about short-term efficacy, potential mechanisms of action, and safety. Taking all data together, inter-articular steroids are a helpful treatment option for patients with knee and hip OA. So it comes as no surprise that most recommendations and guidelines recommend steroid injections, as you see depicted in this overview. And I like the last statement by NICE a lot. It says explicitly that we first have to consider core treatments as education, exercise, and weight management. So in conclusion, single inter-articular steroid injections are helpful in patients with knee or hip osteoarthritis for short-term symptom relief. I thank you for your attention.
Wonderful. Thank you, Margreet.
Good morning.
And now I will hand over to the negative speaker, Dr. Ali Guermazi. Ali, handing off to you. Fantastic.
Welcome all to the Osteoarthritis Summit Debate Series. My name is Ali Guermazi. I'm professor of radiology at Boston University School of Medicine. I am going to take on the harmful side of the intra-articular corticosteroid injection. A quick background. Hundreds of thousands of intra-articular corticosteroid injections are performed every day. The evidence supports only short-term pain relief. Also, I want to just remind everybody that the cardinal rule in medicine is premium non nocere, or first do no harm. And I always heard physicians telling patients, if the injection will not help you, it won't harm you. From the imaging perspective, is osteoarthritis always the origin of the pain? Or in other words, can osteoarthritis on X-ray explain moderate to severe pain? Let's look at some cases from our practice. These 3 patients came to our attention for intra-articular injection of corticosteroids because they have moderate to severe pain, and as you can see, osteoarthritis. This patient has a Cardinal Lawrence 2 with definite osteophyte but no joint-space narrowing, and these 2 other patients, they have Cardinal Lawrence 3 with joint-space narrowing and definite osteophyte. We did not inject these patients because of the pain. So let's look at these patients one after the other. The first one we said, Cardinal Lawrence 2 with definite osteophyte and non-joint space narrowing. We ordered an MRI, and as you can see, the MRI shows a fracture of the medial tibial plateau with this line, which is hypointense T1 parallel to the medial tibial plateau, and then again it's hypointense T2 but surrounded with large bone marrow edema. Stress insufficiency fracture. Here the second patient, Cardinal Lawrence 3, definite joint space narrowing and definite osteophyte, and moderate pain. We did the MRI, it shows cartilage loss, bone marrow edema within the medial tibial plateau, and a meniscal extrusion. An intra-articular injection was performed. 6 months later, the X-ray shows definitely a worsening in the joint space narrowing, as you can see, and maybe a little bit of irregularity of the subchondral bone within the medial femoral condyle. The patient had more severe pain at the follow-up at 6 months. So with that, we did actually the MRI, which shows here a small subchondral insufficiency fracture, which is the hypointense line parallel to the subchondral bone, associated with this huge out of proportion bone marrow edema of the medial femoral condyle, with extension to the lateral femoral condyle, and as you can see, associated with a severe soft tissue inflammation. This is typical of subchondral insufficiency fracture. The third patient, Carver Lawrence 3, definite joint space narrowing and definite osteophyte. The MRI at baseline shows a complete tear of the medial meniscal posterior root with associated severe meniscal extrusion. Injected the patients, and 12 months later, definite loss of joint space width, which is right now looking like bone on bone. But when you look at the MRI, you see that the meniscal extrusion is more severe, but also a subchondral insufficiency fracture at the medial tibial plateau and medial femoral condyle, with again out of proportion bone marrow edema within the medial femoral condyle is extended to the lateral femoral condyle, and within the medial tibial plateau extending to the lateral tibial plateau, associated with severe soft tissue edema at the lateral aspect and the medial aspect of the knee. This is what we see when we have posterior meniscal root tear with a corticosteroid injection. Again, from the imaging perspective, because some of us will inject patients with normal x-rays, the question is normal x-ray equal really normal joints? What really happened for these cases with pain only but no imaging findings on x-ray? And let's look at some cases. Here a patient that was 26-year-old male with moderate to severe pain came to our attention for intra-articular joint injection. As you can see, normal x-ray. But we did not want actually to inject the patient, and we did an MRI. And as you can see here, there is a line of fracture which is parallel to the medial tibial plateau, seen on T1 weighted, on T2 weighted, with extensive bone marrow edema surrounding this fracture line. And this is simply a tibial stress fracture, typical. Second case, 26-year-old female after childbirth came into our attention with a moderate to severe pain on the left hip. As you can see, joint space is normal and there is no definite osteophyte. Before intra-articular injection, we realized maybe we need actually to have an MRI, and that MRI shows an hyperintensity within the femoral neck on T2 weighted and hypointensity on T1 weighted, typical of what we call stress reaction. So no need for intra-articular corticosteroid injection. Time now to talk about the joint events that may be seen after intra-articular corticosteroid injection, which are subchondral insufficiency fracture, osteonecrosis, RPOA type 1, and RPOA type 2. Remember that paramount is definition in regard to terminology. So let's start with rapidly progressive osteoarthritis type 1 and 2. Only sparse data available regarding predictor of RPOA type 1 or 2. These may be characterized by rapid radiographic osteoarthritis onset and rapid progression to arthroplasty, and MRI-defined risk factor for rapid cartilage loss on MRI are meniscal damage, particularly root tears, inflammation, and large bone marrow. So let's start with rapidly progressive osteoarthritis type 1. As a definition, is a rapid loss of joint space on radiograph beyond the expected rate, which is joint space loss of more than 2 millimeters within 12-month period. Sometimes is the loss of half of the joint space within 12 months when we don't have initially more than 2 millimeters in joint space width, or sometimes the progression from a joint space to a bone on bone. These are two cases. This patient has more than 2 millimeters, and 12 months later has actually lost more than 2 millimeters. This patient has a little bit of joint space, as you can see, progressed to a bone on bone. Both of these are rapidly progressive osteoarthritis type 1. Second, rapidly progressive osteoarthritis type 2 is defined as rapid articular destruction with accelerated bone loss, not typically seen in patients with osteoarthritis. When you have a regular osteoarthritis, you don't have a loss of bone. There is no destruction of bone. There is no fragmentation of bone in regular osteoarthritis. There is no loss of anatomy, right? You have it here with RPOA type 2. And a few x-rays detectable conditions likely associated with RPOA type 2, and they are the subchondral insufficiency fracture, osteonecrosis, or large subchondral bone cysts. So let's see some examples. Here at baseline, this patient before injection of intra-articular corticosteroids has a joint space narrowing and definite osteophyte, so typical OA. When you look at follow-up 6 months later, you see that there is a loss of part of the medial tibial plateau, as you can see with fragmentation of the bone. This is not typical for osteoarthritis at all. A second example, you see here, typically this patient is almost normal, a small osteophyte in the medial and tibial plateau, but then after 6 months of injection, you see fragmentation of the bone here, again in the medial tibial plateau. This is non-typical for osteoarthritis. This patient is a 36-year-old female with osteoarthritis, Coggle Lawrence 2 in the hip, in the left hip, as you can see, with definite osteophyte and no joint space narrowing. We did an injection of intra-articular corticosteroids, and 6 months later, as you can see, there is no femoral head. It's all fragmented, and it's ejected laterally to the hip joint. So completely now there is no femoral head, but the neck here of the femur is sitting into the acetabular. This is, as you can see, no X-ray at risk. Baseline pathology was observed at this point. Third safety event, subchondral insufficiency fracture, is defined as a subchondral hypointense fracture line of varying thickness and extent, usually a thin line on hypointense T1, T2, which is parallel to the subchondral bone as demonstrated in the previous slide. It is occult on X-ray at early stage 1 and 2, and only recognized on MRI. If you see subchondral insufficiency fracture on X-ray, it means it's too late. There is a marked surrounding bone marrow edema pattern that is more intense than would be expected of typical osteoarthritis. There is also an inflammation in the same side where the subchondral insufficiency fracture is seen. Let me show here an example. This is a patient that look actually with almost normal X-ray, get actually an intra-articular injection of corticosteroids, and 6 months later, as you can see, joint space narrowing, but irregularity as well of the tibial plateau. When you look at the MRI, there is this hypointense line that you can see here, and you can see here on the sagittal image, which is parallel to the tibial plateau with an associated bone marrow edema and also an inflammation within the joint, soft tissue joint. So this is typical for subchondral insufficiency fracture. Let's look at the last event, which is complication of osteonecrosis. They're usually associated with subchondral femoral bone plate collapse and development of secondary osteoarthritis. Osteonecrosis also is usually occult on X-ray at early stages and only recognized on MRI. Let's look at this patient with bone on bone and medial tibial femoral joint with definite osteophyte. Before we inject the patient because of severe pain, we wanted to look at the MRI, and what we found is here a typical osteonecrosis of the bone, which has the same content than the normal bone here. You see the content of the osteonecrosis on T1 is hyperintense, on T2 is hypointense, surrounded by this hypointensity T1 and hyperintensity T2, which is serpiginous or irregular, which is typical for osteonecrosis. Again, if you look at the image of the medial tibial plateau, you don't see anything. So it's really early stage of osteonecrosis. So let's talk a little bit about the study that we conducted in our hospital. We do a lot of intra-articular injections, as many hospitals do. This is a retrospective data and based on 1 year, complete year of injections. We injected 459 hip and knees, as you can see, more hips than knees. And what we found, RPOA type 1, 26, represented 6%, so really the most prevalent one. RPOA type 2, we find 3 of them, 2 in the hip and 1 in the knee, represented 0.7%. Osteonecrosis, 3 in the hips, represented 7%. And SIF, we have 4 in the hip, representing almost 1%. So as you can see, we find out 36 events representing 8%. Most of them are in the hip, as you can see, more than the knee. When you look at the literature, there is, as I said in the beginning, paucity of relevant studies, but I want to just draw your attention to two studies. One of them is by McAlinden et al. They found intra-articular corticosteroid injection resulted in greater cartilage volume loss than did placebo injections. That means that you have more cartilage loss. Obviously, cartilage loss translates to joint space narrowing, so probably that translates also to a RPOA type 1. And they found as well that there was no significant difference in knee pain at 2 years between the two arms. Simeoni et al. Reported in this retrospective study that is based on a radiological observation that 44% of the 70 patients that they injected in the hip with intra-articular corticosteroid injection showed radiographic progression of osteoarthritis, and 17% developed articular surface collapse, meaning RPOA type 2 in the hip. So let me summarize here. What we saw here is that there is sparse data available on complications from intra-articular corticosteroid injection. We saw that RPOA type 1, RPOA type 2, SIF, and complication of osteonecrosis are possible safety events after intra-articular corticosteroid injection based on clinical observations. The knowledge of saddle imaging findings is paramount. It is unknown if events were already ongoing at time of injection or true complications, because we don't have MRI for all actually this injected patients. From now on, consenting patients for these potential safety events is critical, and it's in line with the do no harm principle in medicine. Lastly, prospective studies are needed to confirm causality and natural history of these possible complications. Thank you.
Wonderful. Thank you so much, Dr. Guermazi. And it's great to see this debate evolving as both participants sit there enjoying their presentations. Just a reminder to all of the participants who are out there on Zoom land, if you want to enter questions, the way to do that is through Slido. So please go along to the website, www.slido.com. You'll see an opportunity to enter this code, 153915. And there you'll be able to enter your questions, but also vote on other people who are entering their own questions so that we can focus on those top vote questions. But without further ado, and Margreet, if you want to look at those questions as they're coming online, again, www.slido.com, and the code is 153915. Not sure if you've got an extra screen there, but it might allow you to look at the questions in advance. Excellent. Now, each of the speakers thoughtfully thought about the opponent's slides and have prepared a rebuttal. And again, amazingly, the speakers will sit there as they speak to themselves and enjoy that presentation. So I'm going to now get Margreet to respond to Ali Guermazi's sensational presentation and hand it off to Margreet.
Thanks, Dr. Guermazi, for an excellent overview. I have some remarks. Dr. Guermazi presented an observational study in knee and hip patients receiving a steroid injection and showing rapid progressive OA and joint destruction at follow-up. The question is, however, whether there is causality between the injection and the arthropathy at follow-up. To study causality, it is important that the outcome is not already present at the start. As Dr. Guermazi pointed out, in this cohort that was not the case. A 69-year-old woman participated in the study with a subchondral insufficiency fracture, which was already there before the study, the steroid injection. This makes a causal relationship unsure. Causality can be addressed in case control studies. Studies by Simeone and Zeng and their colleagues suggest that progression of OA and collapse are seen more often in the cases. However, as also clearly pointed out by Dr. Conaghan in a letter to the editor, these studies are difficult to interpret due to confounding issues. RCTs comparing steroid injections to placebo could be helpful when it is such a frequent side effect as suggested by Dr. Guermazi. No differences were reported between the groups of this type of side effects in the RCTs by McAlinden and Renault and colleagues, studying repeated steroid injections for 2 years. Even in all 104 patients on steroid injections, none were reported. So causality remains unsure. Dr. Guermazi suggested a prevalence of up to 10% of rapid progressive OA and joint destruction, especially in the hips. This is a very high percentage and strike me. Could this have to do with the patient selection? What was the diagnosis of the patients? Inflammatory rheumatic diseases, lupus or post-traumatic? What was the current and past co-medication? Oral corticosteroids, methotrexate, NSAIDs? Are these patients similar to the primary knee or hip OA patients? We have to see the frequency of these joint events in the context of natural occurrence. Rapid progressive hip OA is regularly described in case series, first by Forestier in the 50s, later by others. For instance, Rosenberg reported these, pointing out that it was not in patients on steroids. Recently, in participants with knee pain with a presumed meniscal tear, nearly 3% had a subchondral insufficiency fracture. Finally, a lot of data came out of the NGF inhibitor trials. Hochberg showed that the frequency of joint destruction and rapid progressive OA in the control group of NSAIDs was 1.5%. So we can conclude that these joint events are regularly taking place, apart from the use of steroids. To conclude, I refer to Dr. Guermazi about rightly informing our patients. I totally agree that physicians should not tell their patients that if the injection will not help you, it will not harm you. We all know that all medicines can cause unwanted side effects. It is also the reason why we, as physicians, inform our patients extensively, ask for consent, and take precautions to prevent side effects. The question is here whether the benefits outweigh the risks in a particular patient. Given the efficacy data, the known side effects that can be taken care of, and lack of evidence about joint destruction and rapid progressive OA, these injections can be helpful and recommended as done by many guidelines. I thank you for your attention.
Wonderful. Thank you so much, Margreet. Tremendous response. And I'm sure Ali is quivering in response to the withering words of Margreet. And now I'll hand off quickly to Ali so he can resurrect himself after that withering presentation. Ali.
Welcome back to the rebuttal. I am going to discuss 3 points. The first one are intra-articular corticosteroid injection efficacious. Second, are they safe? And third, is X-ray enough to understand the origin of joint pain? So let's start with the first point. Are intra-articular corticosteroid injection efficacious? Not all the time, and when they are, only for short term, less than 6 weeks. There is no long-term effects, and mechanism is not well understood. Also, we know that intra-articular corticosteroids treats inflammation, but not the underlying trigger of synovial activation, which are structural joint damage and especially synovial damage. This is a recent EULAR recommendation for intra-articular therapies, which was published this month. What it says here that intra-articular corticosteroid injections are indicated for acute exacerbation of osteoarthritis pain with effusion, and that acute or recent onset of joint swelling should not have intra-articular corticosteroid injections unless appropriate diagnosis is made and contraindication are ruled out. Another publication from last month, which is a systematic review with meta-analysis in the randomized control trials. You can see here that the reduced pain and improved function was only for less than 6 weeks, and there was no effect from corticosteroid injection at 24 weeks. Now, the second question, are they safe? We are not sure anymore. Observational data showed increase of safety event like subchondral insufficiency fracture, osteonecrosis, and rapidly progressive osteoarthritis type 1 and 2. These adverse events are not known to be either ongoing before or caused by the injections. And we need randomized clinical trial to understand the pathophysiology and natural history of these adverse events. Let's move to the third question. Is X-ray enough to understand pain origin? Of course, no, because osteophytes and cartilage are non-painful. Also, intra-articular corticosteroids injections acts better on synovitis, but this is not seen on X-ray. And the question here, how about intra-articular corticosteroid injection of painful but structurally normal joints? This is very much discouraged because other diseases entity may be ongoing and may be exacerbated by intra-articular corticosteroid injections. We published some guidelines from the scientific expert panel, and we agreed against intra-articular corticosteroid injection in normal X-ray, and we also agreed against intra-articular corticosteroid injection in out of proportion pain not explained by X-ray findings. Here is a suggestion of pre-procedural imaging algorithm from the same expert panel. We start with an anterior-posterior X-ray of the joint. If there is no radiographic osteoarthritis or radiographic suspicion of any adverse event, we should not inject corticosteroids. If there is no radiographic findings but clinical suspicion of possible adverse event, then we go actually to do an MRI. If the MRI shows no finding, we can do the injection. If the MRI shows some findings of adverse event, no injection. And finally, if no X-ray finding and no clinical suspicion of possible adverse event, consent the patient for possible safety events that are osteonecrosis and RPOA type 1 and 2, and then perform the intra-articular corticosteroid injection. So in summary, there is no long-term efficacy from intra-articular corticosteroid injection. If there is any, it's less than 6 weeks. Second, likely not totally safe regarding structural adverse event that we described, such as subchondral insufficiency fracture, osteonecrosis, and RPOA type 1 and 2. Imaging may help, but certainly not X-ray. And finally, maybe we should actually stop injecting corticosteroid intra-articularly in a non-inflamed or non-osteoarthritic joint. Thank you very much.
Wonderful response. Thanks, Ali. And now we're going to open up for question and answers. So we might unmute Ali and Margreet and allow them an opportunity to address the questions that are popping up in Slido. For anybody who hasn't entered a question in Slido who would like to, the details are on the slide there. And I might pose the first question to Ali from Chris Little. And it really is relating to the cause and effect. For RPOA type 1 and 2 and spontaneous insufficient fracture and osteonecrosis, are they only seen following an intra-articular corticosteroid injection? And if not, could they be occurring anyway?
It's an excellent question. We don't know. I mean, the answer is we don't from the perspective of intra-articular corticosteroids injection, but we know that they exist, of course, in regular patient that they come for pain and they don't actually, we don't have intra-articular corticosteroid injection to do. They just have a severe pain or moderate to severe pain. We do the MRI and we find them. That's one. We know that they exist also with other, injections or other medication that was described, for example, for the anti-NGF. And there is many papers talking about it. But I think from the RPOA type 1, the one that we saw in this prevalent, when you look at the randomized clinical trial by Macadindin, all right, that's actually really a double-blind randomized clinical trial. It shows that these patients lost cartilage, more volume of cartilage than actually placebo. And what does it mean? You lose cartilage volume. It means also you lose the thickness and you lose actually the joint space. So I would think that some of it is true, but we need also more studies to really confirm that, and especially also to show if the other three, meaning RPOA type 2, osteonecrosis, and actually SIF, they exist or not after, or they happen after actually intra-articular corticosteroid injection, or they really existed before even the injection. And we don't know, or we didn't know because we didn't have MRI for those patients.
Wonderful. Thanks, Ali. Lon or Vicky, we lost Margreet. If you could just pin her back to the screen.
Yes, I can see you.
Okay, fantastic.
And I can hear you. So
Excellent. All right, Margreet, very nice presentation. Now, since most of evidence of the corticosteroid injection is found for knee and hip osteoarthritis, would you expect similar effects in hand and foot osteoarthritis?
now, the site where also much studies have been done is for thumb-based osteoarthritis, and the studies that have been done there did not show efficacy. Maybe that could have to do with the fact whether there is inflammation, yes or no. I think when you look at all the studies and think about the mechanism of action, then we think it works via an anti-inflammatory way. In thumb-based osteoarthritis, you have often a lot of osteophytes. And when you then put there an injection, I can imagine that it does not work. We never, now there have not been studies done in thumb-based osteoarthritis taking care of that. But maybe that's also a little bit in line with what Dr. Guermazi said, that you really should think about in which patients you give the injection. I agree with that.
Okay, fantastic. Thank you, Margreet. Ali, now, why do you think there were more adverse events in the hip versus the knee?
That's again a good question, and I do think it was demonstrated as well for the anti-NGF. Is it the susceptibility, natural susceptibility of the hip? Maybe because also the hips are central to the body. I have really no idea, and maybe because they are small joints compared to the knees, and they are taking care of most of actually our body. And as I said, maybe there is susceptibility. I really don't know. As I said, same thing happened for the anti-NGF. There are more safety events in the hip than in the knee as well.
Margreet, are there specific clinical scenarios or indicators when you would not use intra-articular corticosteroids?
A clinical scenario where you have a chronic pain patient, so the pain where you anticipate that it is not just one injection that's going to help the patient, but that you want a pain solution for on the long run. I don't think that it is a patient for which it's appropriate to give such an injection. You can especially think about clinical scenarios when you want to use an injection. And then I think you have patients with flare-ups, patients that have a specific wish because they are planning to do something in their life for which I think at that moment in time they don't want pain. They want to go to the wedding of their child and really think it would be good to have for 2 weeks no pain at all. Now, for this kind of scenario, I think such an injection would be very helpful.
Thanks,
but
Margaret.
not for any patient. No.
Right, and we might just leave the last question to Ali. This is again from Chris Little, but are there any predictors for negative events following a corticosteroid injection?
So let me just ask, just answer this question in two ways. I don't think there is, or there are predictors that we saw for this particular, events on intra-articular corticosteroids because we didn't do the study. But let's actually go back to what we saw, David. We've done many actually of these studies together. There are studies that are done, elsewhere as well, looking at what we called rapidly progressive osteoarthritis, or what we call also a fast progression. We call it fast progression. Others they call it accelerated OA. This is all the same thing. We're talking about the same thing, all right? So what you see there is that a large bone marrow edema can be a trigger or predictor. A massive cartilage loss at the beginning, at baseline can be actually some of it. But one thing that we didn't look in the past really very, focusing on that one is the root tear, the posterior root tear. We know more and more that when you have a posterior root tear of the meniscus, you are really at risk of what we call it explosive osteoarthritis, meaning something that will grow very fast. And you see actually really joint space narrowing going, from calculon 0 to 4 in 1 to 2 years sometimes. So again, someone can also argue, sometimes you have these root tears really, less frequently, and you don't have anything happening. I would think probably is also about the activity of that patient as well. But these are all, to be honest, speculation, and they should be actually, of course, some clinical trials, randomized clinical trials that show this causality as well.
Wonderful. Thank you so much, Ali. You've done a great job. Now, what I'm going to do is ask the audience to vote, again, based on the original poll question. Remember at the beginning, it was slightly in favor of steroid injections. We might just launch the next Zoom poll and ask each of you to vote and try to understand if that has changed at all between the beginning and the end. So would you recommend a steroid injection for knee osteoarthritis? Again, give you about 30 seconds to hit a button there on your screen. It's going to be amazing, but I think it's going to be exactly the same. All right, we might pause the poll there and show the results. And if anything,
I lost.
The numbers are remarkably similar to the first poll. But the next question is probably more important. So for those of you who are out there, who in your mind was the winner of this debate? Was it Margreet or Ali? So we might just open that poll and again, get each of you to vote.
Can I vote for myself?
Go ahead. Go ahead. Okay. All right. So I might just show those results as well. So Margreet, congratulations. The fairer sex has won tonight. And Margreet, wonderfully well. Well, both of you incredibly well done. But based upon the audience this evening, Margreet is the winner of this debate. So Margreet, congratulations. Thank you so much. The winner is Margreet. Now I'm going to close in just thanking both of the wonderful participants for tremendous presentations and rebuttals, for their good-natured collaboration, the audience questions, and really appreciate everybody's involvement. And look forward to seeing you again when we next do one of these debates. But again, Ali and Margreet, firstly, thank you to you, Vicky and Lon, who've helped to coordinate this, and the various sponsors. Thank you all so much. Have a wonderful evening.